Hello and welcome to Sonoma Valley Hospital's Active Aging 2020 series. We're so excited that you're here with us, and we will begin after a couple of words, announcements, and our introduction. Wanted to thank everyone for being here. Given the situation that we are surrounded by, I think that you'll find today's talk especially insightful, helpful, useful, and informative. Dr. Kidd is going to lead us off with our Active Aging series, which began in 2014. Each year we draw upon the talent and the brains of experts in the medical field to touch upon topics that are relevant to our community. This year we're doing a focus on mental health. We're going to be looking at wellness, and we're also going to be taking a tour inside our emergency department. We have a special session today, and that is given to us by Dr. Kidd, who's going to give us an update on COVID-19 and other relevant matters. I do want to remind you that this is the first in the series. There are 3 talks following. The next talk will be September 17th, and it will be given by Dr. Kathra Halabi. So she is a neurologist who founded and serves as a director of UCSF Neuro Recovery Clinic, which provides care for patients recovering from acquired neurological injuries, including stroke, concussion, and other types of traumatic brain injury. She's very generous with her time, and we're excited that she's going to be here next Thursday at 1:30. So if you have questions, send them to me, Celia. You can call me or you can email me at community@sonomavalleyhospital.org. Our next speaker following that will be on the 24th. That will be with Dr. Jasper. He is the medical director of the hospital's emergency medicine and department. And then our final talk is going to be with Dr. Ellen Burnett, and she's going to be talking about how to move through COVID, how to move with stress, and how to be healthy. I do want to give a special introduction and thanks, Dr. Sabrina Kidd. I believe Dr. Sabrina Kidd is a University of Michigan alum. So that's exciting for those that believe in the big blue back in Michigan. She also did her medical school work at Tulane University. She has a specialized in colorectal surgery as well as general surgery. We are proud and honored to have her as our Chief Medical Officer, and she also serves as the UCSF Medical Director for Sonoma Valley Hospital. Just a couple of housekeeping rules for those who have joined us. If you are looking to participate and listen to our simultaneous Spanish audio, in the lower right of your screen, you'll see a little globe as marked here on the screen. If you hit on that globe, a menu will pop out, and you will see the options of English, German, or Spanish. We are only going to be offering Spanish as an option to English. So when you do that, click on that, and then also please mute where it says original audio. This will suppress Dr. Kidd from speaking, and you'll just hear our interpreter, Amelia Bustamante. So we're very excited about that. Also on your screen, you'll notice that there is a chat feature. This is where you can ask your questions, and at the end of the presentation, we will be taking those questions and giving them to Dr. Kidd for her answers. Without further ado, and much appreciation and much anticipation, I now roll it over to Sabrina Kidd, Medical Doctor, Chief Medical Officer, Sonoma Valley Hospital. Thank you, Sabrina.
Thank you, Celia, for that wonderful welcome. And I also want to thank Celia and Vintage House for putting this on, and also extend my thanks to Amelia for our interpretation today. It's wonderful to be able to reach people in multiple languages in our community. So I'm going to be speaking on COVID today, since obviously that remains forefront in many of our minds. What I hope to do is briefly cover the state of where we are at, talk a little bit about how we got to where we currently are, and then touch on several recent hot topics, including ongoing testing concerns, concepts of immunity, a little bit about kids and schooling, as well as touching on travel and potential for vaccines and next steps. So I'm going to dive right in and start from more of a global scale about where we are today. This first slide speaks to the United States and comes from one of the first dashboards that was set up, and this is from the Johns Hopkins Coronavirus Resource Center. As you can see, it's loosely in the shape of the United States, depicting each state. And the key here is that we are really all over the map. You can't say that as a country we are up or down. The greener you are, the more you're on a decreasing trend, and the redder you are, the more you are on an increasing trend. So if you look to the left side of your screen, you'll see California over there. Unfortunately, we are back on a downward trend. Not as good as, say, Massachusetts, way over on the East Coast, but very good news compared to where we were perhaps a month ago. Unfortunately, there are new hotspots throughout the country, and these include areas such as North Dakota, parts of Missouri, West Virginia, and Delaware. Louisiana, which was also initially hit very hard, has initially had another spike as well, and there's concerns that following the recent hurricane, this could increase further. So how about a little closer to home on the statewide level of California, how are we doing? As a state, we, as many know, we had the earliest shelter in place, and initially that served us very well. However, come late June, early July, we saw numbers spike, and we saw our test positivity rate rise above 8%. We saw our hospitalization spike. And initially we thought that the Bay Area would be different, but we were not. And that summer proved to be very challenging for California and as a whole, including the Bay Area. The good news is that in the last 2 weeks, we've seen that trend reverse and rates have dramatically decreased. On a state level, the test positivity rate is now just below 4%, which is excellent news, and demonstrates that it's not just that we are not testing, this shows that we are testing, but the number of positives relative to the number of tests is lower. On a statewide level, you'll notice on the right side of your screen that the deaths also look to be decreasing somewhat, but as expected, deaths lag behind case rates, and so that is reflected here. And as the Bay Area, as I spoke to, we did amazing to start with. Our shelter in place was beyond effective and more than we had hoped for. However, as we began to lift restrictions, we know that that did not go well, and we spiked similar to the rest of the state. And that was reflected also in hospitalizations as well as deaths, as you can see in the blue on the right of your screen. What is noteworthy here is that we seem to be lagging behind the state just slightly in our decrease, and our deaths have not really declined yet. I hope that that's just a delay in time scale, but we don't yet know what will come in the weeks ahead, and we still are a long way from the low we were at prior to starting reopening measures in around June 1st. So here locally in Sonoma, unfortunate news is we seem to be the outlier county in the Bay Area. All of the other counties are demonstrating overall downward trends for the last few weeks. And if you look at the bottom of your screen here, the bottom red numbers are the active cases, with the total cases being included in green. So they're taking into an account here expected recoveries and or deaths. And what is noteworthy is that if you look to the far side of your screen here, we basically have a plateau. And so it shows that although we are not continuing to increase in our rate, we have not significantly decreased. And there's quite a lag in reporting the test positivity rate, so that's difficult to quote you for the last week or so. But about 2 weeks ago, it was quoted to be greater than 10%, which actually outpaces the worst that the state was. So here locally in Sonoma County, we still have some work to do. At the hospital level, here are some stats that we've been keeping track of. We have now collected over 2,000 tests to date. Those have been mostly processed through our partnership with UCSF. Through those, we have identified 73 distinct positive individuals, treated many in our hospital, and unfortunately had 3 deaths related to COVID-19 in our hospital. Overall, though, the care has been, I must say, I'm very impressed with our care team, and they've been able, as I will discuss later, to offer all of the recent therapies and seen some remarkable recoveries by doing that. So how did we get here? I'm not going to dwell on some of this very long, as it's getting to be old news in COVID timeline, but I do want to remind just the basics of how we got to where we are today. This has been on our minds and in the forefront since late February, when we began with screening protocols and really just trying to get a hold of what was happening and looking at CDC guidelines. In March, our Incident Command Center, which is our team that is dedicated to dealing with all types of disasters, fully opened, and that brought together about 20 individuals on a daily basis for over 6 weeks to problem solve, find ways to test, and to do surge planning for COVID. During this time, we were in shelter in place, as many remember. And I would like to point out that Sonoma was one of the very early adopters of what we call universal masking, way before it became guidance from the CDC. This was based on research that we saw from some neighboring countries, especially South Korea, that were having much more success. And so we decided to protect the hospital and our staff, as well as the patients, as best we could with that science to date, and it has proved to be a very successful strategy. During this time, we also set up a nurse-run hotline, initially for symptom checking and for testing, that later became just for testing, and it's since transitioned further to be just for drive-through testing. We also took advantage of our affiliation with UCSF, and the affiliates network really came into its own during this time. It's been an amazing partnership that has given us access to a lab, to testing supplies, to algorithms, treatment decisions, and as many know, we have an infectious disease partnership that we began in January of this year, before we knew about COVID, with UCSF. That provides telemedicine services to us, as well as a medical directorship, and that too has proved to be an invaluable clinical resources for us at Sonoma Valley Hospital. So as April turned around, we all began to realize that this was going to be a lot more than the 3 weeks of a temporary shutdown, and we began preparing for really the near future. This meant finishing our surge preparations, which expanded us to 59 beds, a lot of additional staffing plans, opening the old emergency department should it be needed, and then finally transitioning to living with COVID, which meant developing an exit strategy. In May, we did begin opening some of the services that had been put on hold. We saw some stabilization initially in our PPE supplies, and we really started living with what has become our new normal. By June, all services were reopened, and we further partnered with UCSF to continue pre-op testing, not only for the patients at Sonoma Valley Hospital, but also for those through UCSF that live in our area. And that continues today and has been a very successful partnership. Unfortunately, as we talked about in the beginning, in late June, early July, locally, we began to see the effects of increasing numbers. This was thought to be related to celebrations throughout some of the summer holidays, as well to some of the reopenings that did not go as planned. With that, we reopened our mini incident command center on a scale back. We were now mindful of resources because all services were again open. So the challenge at this time began to be keeping all services open, but dealing with the kind of moderate numbers that were not a full surge. We were very lucky to add a very talented infection preventionist to our team over the last month or so, and that is Ms. Leah Heinrich. She's been a wonderful addition and helps keep us all up to date on changes, also can do in-depth clinical assessments for us in contact tracing, and really is a very valuable resource to the hospital and translates to the community as well. And if COVID wasn't enough, as this time has progressed, unfortunately we added another disaster to our plate, and that would be the fires combined with the air quality and the possibility for the public safety power shutoffs. So in the past, our Incident Command Center has been used to deal with each of these, and fortunately or not, we have experience in this area over the last few years. So at this time, although it's been a large concern, we were ready and prepared to deal with this. We've deployed our air scrubbers and continue to monitor the situation carefully. We do have purple air monitors if anyone is curious, one inside and one outside of the hospital, so we know at all times what the air quality is like in our facility. The one piece of really good news that we've had in the last month, I will say, is that since the beginning of this, we have been challenged regarding testing, and we have at this point secured a machine to do in-house PCR testing. As I will discuss in a bit, we're still facing supply challenges, so it's not quite ready to go, but it is a huge step in the right direction. So, as I mentioned, testing, let's dig into that a little deeper. And any conversation where you're getting testing, it requires a few definitions. So what kinds of tests are out there? I think it's useful to think of them in a couple different categories. Diagnostics helps us identify or eliminate the possibility of a disease, where epidemiologic and others may be more on a population basis than an individual basis. Some of the diagnostic tests, what has become as our gold standard, is known as the PCR test, or polymerase chain reaction. This takes a sample of the virus, usually from deep within your nose, the nasopharyngeal swab. That's the uncomfortable brain tickling, as we like to say. And then it hopefully identifies a very small piece of virus, but then can amplify it through replication to confirm its identity. And that's the basic science in a very simplified way behind this. As I will tell you later, that is considered our gold standard, but it is far from perfect. There are many other tests out there, the point of care tests, antigen tests, rapid tests. These overlap with different names, but in general, these are antigen-based tests which identify a protein on the virus. Overall, these are useful, but not the gold standard. They are accurate in some situations, but not in all. So our use for those is mainly in symptomatic individuals. And if they are negative, depending on the clinical scenario, the test may need to be confirmed with a PCR test. There are saliva tests, finger stick, many others out there, but none of those have rolled out into mass production at this time or easily available. And overall, they are thought to have a lower accuracy, but there's a lot of science left to be determined in various other testing modalities. Epidemiologically, antibody tests were the big talk at the beginning of this disease. And that has since waned a little bit as we have learned more, and we are not sure of the role of antibody-mediated immunity in the coronavirus. So we were very cautious with this, but we do have the ability to perform these tests at Sonoma Valley Hospital if needed. The evidence for what a positive test indicates clinically is still very limited, and I'll talk about that a little bit more as we proceed. But as a recent article did hit some mainstream media has highlighted, and this is largely actually from researchers at UCSF, they believe that T-cell regulated immunity, which is a different kind than antibody, may in fact be more important than antibody-mediated immunity in the coronavirus. So more to come, but that's the current thinking on that. So as I mentioned, there's been a lot of questions about how accurate are these tests, and is it user error, is it lab error, is it the test itself? And you know, full transparency, it can be all of the above. And those things usually fall into two different categories in a broad sense, which is false negative or false positive. So a false negative test is when you're given a result that says, hey, you don't have COVID, but you know, guess what? You actually do have it. And so that could be discovered based on your symptoms by subsequent tests, or maybe just never discovered. A false positive is the reverse, where you're told you have the disease, such as COVID, but you do not actually have it. And that can happen for other reasons. The false negatives with COVID, we know that if your viral load is low, that this is more likely to give a false result in our testing. And that is more common very early when you acquire the disease, 1 to 2 days after exposure. And then the viral load seems to drop after about 7 to 10 days as well. So either early on or later in the disease course, the test may be less accurate. As far as the false positives, we have seen this with antibody tests for sure. Initially, some of them were not developed correctly, and they were cross-reacting with other coronaviruses, such as the common cold. We may also see this concept, although slightly different, when a PCR test picks up possible dead virus. So some limitations of this are determining whether the virus that identifies is actually active and able to infect another human being. And our tests cannot 100% determine that. And that is where some of the false positive results may come from. So why do we have this problem? Well, I'd like us all to remember we are in a pandemic, and the US, is very proud of the fact that we have vigorous testing protocols for just about everything. Our testing of any device, anything that is made to the public, has to go through extensive trials before it's allowed to be used. However, we have a mechanism to waive those extensive testing protocols, and that's called emergency use authorization. Because we are in a pandemic, that is the way all of these tests have been approved and released. So none of these have gone through vigorous testing. As we are now 6 months into this, we have learned a lot more. So they've been, on the fly tested, but it's not what we're used to where that testing happens prior to release. So we do know that it was problematic with regards to the early PCR tests. In fact, the ones that the CDC originally released were not at all accurate and were contaminated. So that we lost several days over, if not weeks. We also know, as I mentioned before, some of the rapid antigen-based tests turned out to be not very reliable for individuals that were asymptomatic or pre-symptomatic. We also, as I mentioned, found out that many of the early antibody tests picked up other viruses and were very unreliable. Since then, many of those have been taken off the market, but there continue to be new ones developed, and we are learning as we go. So just to emphasize again, the PCR test is kind of considered our gold standard for this disease at this time. It is still 6 months in, the best we have, but it does have up to a 30% false negative rate when you consider many different variables. Each individual test, most people think if it's done correctly, is more of a 10 to 15% false negative rate, but if you include all the possible variables, it can be even larger. So you can see why testing is very imperfect even 6 months into this. To further complicate the picture, we have to remember what a test indicates. With anything we order as physicians, we always need to stop and say, what am I testing for? When I get a positive or when I get a negative, what does that actually mean? Well, with COVID, we need to realize that this is retrospective, meaning it reflects our past behaviors and exposures, not where we're necessarily at the day we get the results. And that's because of the delay in processing. So as this graphic illustrates, if you get a test on Monday and you have numerous exposures throughout the week and don't get your results until Sunday, that does not mean that you do not have COVID on Sunday. It means that on Monday you didn't have COVID, and that's a big difference. So we need to be very careful in how we use and interpret testing results. And that's also led to a lot of confusion and a lot of change in guidelines. So before we get into some guidelines and some other issues, I want to touch a little bit more on immunity. We were talking briefly about antibodies versus T cells, and those are just two different types of cells or proteins in our body that help in our immune response, our body's ability to fight off disease. Antibodies are blood proteins. They basically identify a foreign visitor or a virus and try to fight it off. T cells are a type of white blood cell, specifically a lymphocyte, that has other characteristics to identify a foreign invader and fight it off. In coronaviruses specifically, not just the SARS-2 coronavirus COVID, we think that T cell immunity may be more important. The downside is both can fight off disease, but antibodies, we have a pretty good way of measuring. T cells, we don't. They can be, T cell immunity can be measured in a lab. From what I'm told, it's quite cumbersome and it's very unlikely to be able to develop a commercial test that can really measure T cell mediated antibody to a coronavirus at this time. So what about the concept of herd immunity? This is a big debate in the literature and on social media about why don't we just go for herd immunity? Well, first let's talk about what herd immunity is. This is the concept that if you have a probability, basically, if you have 10 people in a room and 5 of them have had the disease and 3 of them have been vaccinated, what's the chance that the remaining 2 will actually be exposed to somebody who has the disease and get it? Well, by probability, their chances are much less because overall 8 of those people are supposedly immune. So I hope it's a little bit of an odd concept. So there's different ways of getting to immunity. It could be through vaccination or through having the disease. So through a natural process or through a vaccine. You put the two together and you can get herd immunity much faster and easier. So the next question is, well, how many people on a probability, look at the math and the statistics, need to have either had the disease or be vaccinated in order to offer immunity to the rest of the population? And with everything COVID, nobody can agree on the number, but in general, at least 60% of the population is what is thought to be necessary in order to get our population to herd immunity and get the disease under control. Well, what's the problem with that? There's numerous. One, we know that more lives would be lost if we got here. This is a disease that the death rate is higher than the flu, and people do die from. But further, the stress on it and the peaks on healthcare system are a huge cost. We've already seen the impacts on hospitals going bankrupt, on physician fatigue, on nursing fatigue, on staff, on burnout, and not to mention, so the healthcare system is what I'm saying could be completely broken by all of these cases happening at the same time, or even spread out with constant high volumes, which is part of what we've seen, that you just don't get a break. We don't necessarily have the PPE for that, and we know that when our healthcare system is stressed, as we've seen in places like New York, the death rate skyrockets. We also saw this in Michigan. So what we've learned is why some of our death rate has gone down actually in the last few months, or we've kept it controlled, is because we've developed therapies, because we have the ability to treat people in the ICU and see them recover even from severe disease. If our system was overwhelmed, our ability to provide those resources would go down. So allowing for herd immunity to occur would require a great cost to not just individuals and lives, but also to our overall healthcare system and the providers. Further, we now have information that an individual can get reinfected with the coronavirus. There's been 2 instances now where we actually proved this through gene sequencing. That was, basically the same coronavirus, but 2 slightly different strains, and that 2 different individuals fully recovered from one and have been reinfected. So that tells us it's probably happened on a much larger scale, but those are the 2 cases that we've proved in the world actually at this time. One's in the US and one was overseas. So when we know that, and know that immunity and antibody immunity at least seems to decrease after about 3 to 6 months, it tells us that herd immunity may not be possible through natural means. We may need a more effective vaccine in order to get us there. So we've talked a lot about testing, a little bit about herd immunity. There's all these guidelines out here, and I want to touch a little bit on who should be tested and where the science is coming from. But before I do that, I want us to think back to the beginning of this pandemic. And one of the things, we didn't have tests. And so we had to learn basically how to function and how to treat patients in the unknown. Well, what we learned very quickly is we got limited testing supplies, is that they're kind of 2 different categories. And we've seen them now know that about 15% of individuals get severe disease needing hospitalization. In those individuals, it's very important to know exactly what they have, and because the treatment we now know for COVID is slightly different than for other pneumonias or severe ARDS diseases. And so testing is very important in that population. Testing is also very important to help with contact tracing. But in the absence of testing, it doesn't mean we can't treat people. We can still treat symptoms, and we know that if anybody has mild disease and is able to quarantine, that is definitely something that needs to happen. How we just spoke about, our tests are imperfect, and if they have up to a 30% a false negative rate, they really can't be trusted to say you don't have the disease. So a negative test is not necessarily a negative. If there's been an exposure or any symptoms, we need to assume that it could be a false negative and that the person has COVID. And thus quarantining for 14 days is the right answer. And so the back and forth on testing guidelines, some may be political, some may be supply, but from just a purely how to treat an individual perspective, the safest thing to do is if there's been an exposure or a person has symptoms is to quarantine for 14 days. And of course, seek medical care if the symptoms become severe, in which case testing will be done in most cases. So a lot of this hit the mainstream media recently because the CDC changed their guidelines. Unfortunately, I think it very much confused the picture. It was reported saying you don't need a test if you're asymptomatic. I've copied here, I know it's wordy, but I think it was important to actually look at the language that the CDC put out there. And what they said is you do not necessarily need a test unless you're a vulnerable individual or your healthcare provider or state or local public officials recommend you take one. So basically a lot of this is putting it back into local control, allowing for some variation, whether that be helpful or not, and saying for those reasons that I just spoke about that a test isn't necessarily the right answer in all cases because our testing is unfortunately very imperfect, and that it is very important to monitor one's symptoms, to isolate and quarantine, and to seek medical care if your symptoms worsen. So what are the current testing guidelines locally? Well, in early August, I believe, the state put out some guidance on priority testing, and this was followed up by an order from Sonoma County. That order is basically summarized here, and it prioritizes who should be tested. So first off, any individual who's severely ill. So if you have signs and symptoms compatible with severe illness and you need to be hospitalized, absolutely first priority. Beyond that, we need to protect the individuals and identify early who are taking care of them so that we can stop that spread to these very high-risk individuals that we know are dealing daily with positive cases. Those include healthcare personnel, first responders. We are all well aware of the very unfortunate outbreaks we've had in skilled nursing facilities. So residents of skilled nursing facilities as well as staff and caregivers are included in that list. The homeless are also a very vulnerable population with not always
como las personas que han sido desacomodadas de sus casas, las personas desamparadas y personas encarceladas o que trabajan en una cárcel o prisión. Más que nada para controlar todos los casos que no hay. Es importante que si una persona con síntomas tiene que ha tenido contacto directo con alguien, es importante confirmarlo con un examen de laboratorio. Y son cosas que hemos tratado con los expertos y con el servicio de salud pública. Los exámenes en el hospital de Sonoma ha bajado un poco de velocidad. Pruebas con acceso desde el automóvil todavía puede pasar, no solamente que es para las personas que van a tener procedimientos quirúrgicos. Todas las personas que han sido hospitalizadas y todas las personas con síntomas que llegan por la sala de emergencia son también examinadas. Esto ha sido gracias al laboratorio de la Universidad de San Francisco. También tenemos que ser más conscientes sobre usar el uso del protector físico. Usualmente los exámenes tardan en regresar en 24 horas. Como mencionó antes, una de las preguntas nuevas es que ella nos ha permitido mantener los exámenes
supplies. We were basically given enough to set up the machine and do the verification process, but the company has not yet given us our allocation or been able to tell us what that will look like going forward. And this is something that everyone is struggling with. I know there's been a lot of frustration in the community about limited access to testing, and I share your frustration. It is purely a supply and demand driven issue. In a previous talk I gave a couple months ago, I believe that I discussed the fact that the amount of cases and the amount of tests done versus the amount of material. So it's not that we haven't ramped up the testing supplies. They've actually done an incredible job, but in that same amount of time, the number of cases has just outpaced it, and therefore the need for testing has outpaced any possible supply chain. Therefore, that's what's driving the limited supplies. It's not willingness. Believe me, the hospital would love to be able to open up a clinic to the general community. However, we are forced by limited supplies to adhere to those strict prioritization at this time. If and when that supply chain opens up, I know a lot of individuals are very interested in expanding testing as we are able to. When we do have the machine up and running, we anticipate a 2-hour turnaround time and to be able to run 6 samples at once. As I mentioned earlier, we do have in-house antibody testing available. I am reasonably confident that this is an accurate IgG test. Its usefulness remains limited, but it does sometimes help in difficult cases as an adjunct in diagnosis or recent exposure and helping fit together a clinical picture. So it is a tool that we're happy to have in our arsenal, shall we say. So let's talk a little bit more about risks and what we call mitigation, or what we can do to minimize our risk. And we're going to get into masks and some other details in a minute, but first let's define what is risky or not risky. And to me, that comes down to, I believe, 4 different criteria. The first, and what this table demonstrates, is PPE. So that's very important, obviously, in the hospital, and we have extensive algorithms, but it's also important in the community. So we need to think about, are you masked? Are you unmasked? What type of mask do you have on? Did you have eye protection? So that's the first PPE thing. And basically the concept is 2 individuals masked and or with eye protection, you are in a low risk category regardless of your exposures. If you are both unmasked and no eye protection, you're automatically in the high risk category. And that's just a general concept to keep in mind with a lot of gray area in between. The second concept is distance. The 6 feet rule comes from how far a droplet spreads on average from, say, a sneeze or a cough. It's not a magic number. Farther distance is obviously better, and less distance is obviously not as good. So that is very much an average, and a guideline is to kind of spread out your arms and keep your little bubble, so 6 feet or more. The next concept is timing or duration of contact. So another general guideline is it may not happen with just a passing moment, but if you spend more than 15 minutes in direct contact unmasked, you're definitely in a high risk category. So think about the time, 6 feet, 15 minutes. And the final criteria to look at is the ventilation. So we think most people have learned well now that indoors is not really our friend right now, except we've got the fire situation. So we'll talk about that in a minute, but with COVID, outdoors is your friend. And that's because of ventilation. So anything we can do indoors to increase our ventilation also helps. That means keeping windows open when we're not in fire restrictions. Also using things like air scrubbers or other filters that you may be able to use in your house can be effective. Also, there are ways to do basically air exchanges. So there's negative pressure rooms in the hospital. We are also able to use our air scrubbers to assist in increasing the turnover time of the air exchange, and that helps basically clear the air. So there are ways to do this indoors as well, but in general, indoors is more risky than outdoors simply because of the ventilation. So let's talk a little bit about what we can do and what we probably shouldn't be doing. I think this is kind of becoming old news, but I think we know that it doesn't matter if you're outside or inside, crowds are just not your friend. These can turn into super spreading events. We've seen this from the motorcycle rally that was in the Dakotas about a month ago. There's been now several thousand cases that have been linked to that event, and that was an outdoor event, but largely unmasked and without many mitigation measures. These are just unfortunately not safe in the time of COVID. What I think is a little bit more challenging is getting to the fact that realizing that even our friends and family and those we trust could potentially have COVID, and that you can never be too careful. So what we thought might be safe with a little outdoor meal with some friends or family may not be. If we're not wearing masks and we're not spending our 6 feet apart, we're still at risk no matter who the individuals are. Finally, and we'll talk a lot more about masks here in a minute, these masks with the one-way valves on them are definitely not your friend in a pandemic. They were designed for things like construction work where they definitely protect the individual, but unfortunately that valve allows that individual's breath to spread into the environment and thus puts all around you at risk. So definitely these are not a good idea for COVID risk mitigation. So here is a table that I found recently. I think it was published in Business Insider actually, and you can see the sources there from several well-respected universities compiling different studies about masks that have been done over the last few months. I found this interesting for a couple of reasons. I think as many people know, a true N95 mask is the best protection against this disease. This comes down a little bit to, is the transmission droplet or aerosolized? And the answer is it's probably both to some degree. The majority by far is droplet, and we know that because even though the spread of COVID is not good, way worse than we ever hoped for, it is not to the point of a disease like tuberculosis that is known to be aerosolization. We would not see success with our surgical masks to the degree we do and into healthcare scenarios to the degree we have if there was a larger degree of aerosolization component to this. So there's more and more evidence showing that yes, this can be aerosolized if someone is coughing on you, actively sneezing, being intubated, and you're blowing the virus around in a closed environment. That's where you're going to get the virus hanging around and some aerosolization potential transmission. But for the most part, we believe it is more droplet based, and that is why a lot of different styles of masks can be effective. So overall, we found that simple surgical masks that thankfully have not been in short supply are very effective, and they even have about a 90% effectivity for aerosolization. So they're not ineffective by any means. Hybrid mask is kind of an interesting concept. There's different ways of defining them. In my mind, I also put the KN95s in this category. Those are not built to US NIOSH standards, shall we say, and they have ear loops instead of the bands that go around your head. The biggest problem with these masks is how they fit. A surgical mask typically fits a little tight around the face, and fit is a big thing when we're talking about preventing transmission. You need to keep your particles to yourself. So if there's leaks in the mask, which tend to happen with those hybrid or KN95 masks, that is where you're going to have an increase in transmission. The really great news is that we've now found that a simple 2-layer cotton mask is basically almost as good as a surgical mask. So it's definitely as good, if not better, when it comes to droplet transmission, and not that bad when it comes to aerosolization. So especially if you're keeping your distance and are outside, it is going to work for the general public. It shouldn't probably be used as the primary method in a healthcare setting, but just about everywhere else, it'll do the job. Anything below that layer, when you start getting to tea towels, dishcloths, the gaiters that are made of different fabrics, cotton t-shirts, silks, bandanas, and of course the one-way valves, they're just not as good for many reasons. Mainly that there's holes in the cloth or the weave is not as tight, and so little particles can escape in different situations. And again, a lot of it comes down to the fit over you, but if at all possible, sticking with the good old 2-layer cotton mask, which we're now fortunate to have widely available, is the best option for the general public in most settings. So there has been a fair amount of surprising resistance, at least in my mind, to wearing masks, and some of this comes from not understanding the science behind that. So I just want to cover a little bit about some myths regarding masks and the science that we have to date with their use. So first off is, well, if I'm outside and sunlight kills the virus, why would I need a mask? Well, that doesn't really affect you if you recall back to if you're sitting across from somebody at a table and sharing a meal and breathing on each other, sunlight's not going to have a chance to kill that virus between when it transfers out of their nose and into your mouth. So you have to think about, yes, it can kill it on a surface, but it's not necessarily going to stop the transmission in between individuals. That's where you're going to need to rely on a mask and distance between you so that those particles can't make a direct path from their nose or mouth to yours. The next thing is very unfortunate is that we were all very misinformed early on in this pandemic. And the general advice was to only wear a mask if you were symptomatic. At that time, we were not aware and did not have the knowledge of how much transmission was happening behind the scenes, meaning pre-symptomatic or asymptomatic carriers that were actually very much able to infect and cause another individual to be symptomatic. We now know that that can be the source of transmission up to 50% of the time. Therefore, you can't choose how you feel as to when you wear a mask. The rule has to be universal. The next one is that, well, it's just going to trap the virus and contaminate me. There's absolutely no evidence for that. And I can tell you from years of experience wearing masks as a surgeon, we've not seen that occur. But it doesn't mean you shouldn't handle them carefully. General advice is if you have a cotton mask, if it feels soiled, it gets wet, then grab another one. So keep a few on hand, wash it daily, and handle carefully. At the hospital, we always make sure that we fold them so that the side against our face, if you are using them, is together. So the outside is the outside. If it has ear loops, handle it by the ear loops. Don't touch the cloth. And then put it in a paper bag to store it so it can ventilate and air out, or hang it somewhere else if you have the resources to do so. So the other big complaint has been, well, these are uncomfortable, right? And I feel short of breath, so it must be reducing my oxygen levels. And this is difficult because I will fully admit they're uncomfortable, and especially when you're exercising, you get that feeling of I can't breathe. But that doesn't necessarily correlate to oxygen and carbon dioxide levels that are actually important in respiration. So we've actually studied this, and masks do not reduce your oxygenation. And we can tell that, and many people can do it on their own now because the home pulse ox monitors have become very popular. So if you want to do an experiment, put a pulse ox on you, put your mask on and off, and do some deep breathing, and I would expect you'll see your numbers stay stable. I'll also say that we have years of experience wearing these. As I mentioned, I am a surgeon. I've been wearing a mask for 15 years for work, and around individuals in the OR doing the same, and none of us are having oxygenation issues that we're aware of due to masks. So I think we have a lot of evidence that they are safe to wear on a regular basis. The final thing has been the idea that only the 95s can do anything and we can't get access to those, so why bother? I hope we've covered that in the previous slide, so I won't dwell on that too much. Basically, a proper fitting cotton mask is well worth the investment. So again, what can we do? I can't emphasize enough universal masking, and it's important to remember the concept of I protect you, you protect me. That means both individuals need to be wearing a mask in order to really mitigate this disease. And the next two principles can't be emphasized enough either. Washing our hands frequently is still a really good practice. The virus has to get into our body. So if we happen to touch something or somebody else sneezes or gets to our hands, if those never reach a mucous membrane and can't get into our body, we can't actually get infected. So that's why hand washing is so important. And I think another early on myth was that hand sanitizer was somehow better. It's actually the reverse. Good old just normal soap and water is your best friend. If you are going to use hand sanitizer, please keep some on hand where a sink isn't available. Make sure it's at least 60% alcohol based. That will work well for COVID and other common respiratory illnesses. And finally, keep our distance, 6 feet or more, and stay outside if at all possible. So if you want a little more science to share, I think we all know that both pre-symptomatic and asymptomatic transmission are possible. If we look around the world, we are seeing lower death rates and case rates in countries where the cultural norm is to wear masks or where government policies favor them. We also have some great evidence from here at home. A couple months ago when Missouri was opening up, there was a hair salon where they fortunately had all of the stylists wearing masks as well as the patrons, but unfortunately the stylists had COVID and did not know it for quite a few days when they treated 140 individuals got haircuts. Well, then those individuals were actually all traced and followed up, and about half of them were tested and the rest were monitored for symptoms, and absolutely zero tested positive or developed symptoms. And that is just with an everyday cloth mask on both parties in an encounter that is often 30 minutes or more and indoors. So even in those circumstances, we know a regular cloth mask works very well. Further research and epidemiologists have looked at this closer, and it is estimated that if 80% of our population were to wear masks on a regular basis, that would be more effective than a strict lockdown, and that we could really gain hold of this disease in 4 to 8 weeks. So I think that's a lot of incentive for many individuals that our country could actually function more, quote, normally if we had masks on universally. And if you still aren't convinced and the science doesn't speak to you, well, maybe money does. And I bring this up because recently the town of Sonoma did enact violations, or should I say monetary penalties for violation of the mask ordinance. So now both individuals and businesses can be fined for failure to comply with mask wearing. And this is similar to what has been happening in other communities throughout Sonoma, Marin, and the Bay Area. So important for all, and trying, if, like I said, if science doesn't speak to individuals, perhaps money will. So let's take a break from masks. I think we've nailed that subject to death. And so let's transition and talk a little bit about therapies. So let's start with remdesivir. This is the antiviral medication that received emergency use authorization a few months ago after completing trials that proved no harm and modest benefit in survival. So this has now been rolled out on a larger scale. It is distributed based on need throughout our country. So part of what hospitals and other care facilities do is report daily the number of cases they have, their deaths, the amount of PPE, all kinds of factors. That information is collected on a national basis through Health and Human Services with a pass-through through our California Department of Public Health. And what happens is, all right, we're given an allocation that comes into the state, it gets down to the county, and then the hospitals have been amazing, and they divvy it up amongst ourselves based on census and a need. And with that policy, we've actually enjoyed relative ease in getting remdesivir, and we've also seen it being effective. So this has been part of our treatment regimen from early on and continues to be a successful therapy. It's not a magic bullet, but it's definitely part of the treatment plan. Another part of our treatment plan is convalescent plasma. This is taken from the blood of individuals who have had COVID-19 and test positive for antibodies. That way they get some of the cells transferred to the other individual, and the fact that that will help those individuals who are currently infected fight off the disease. This was originally made available to us by participating in a nationwide study sponsored by the Mayo Clinic, which we were proud to be active participants in. And then recently, based on a preliminary analyzation of that data that basically showed no harm and possible benefit. The study was really aimed to demonstrate there wasn't harm, not to show a defined benefit in death. It was made available via emergency use authorization. So now it is less cumbersome to get and remains available. So when individuals are donating blood, they are also being tested for COVID-19 antibodies, and then they become eligible to be plasma donors. Another treatment that we have available, and this is an old one, but a goodie, is steroids. We know that in some illnesses, the body's immune system or the inflammatory effects overdo it, and that actually kind of the body attacks itself. Originally, and I'm going to talk a little bit about what we think now, but originally this was thought to be a so-called cytokine storm. We have new evidence that shows it's not actually cytokines mediating this storm, it's possibly a bradykinin storm. But anyway, about it, part of the fighting this seems to be steroids, specifically dexamethasone seems to be effective, but again, this is for the critically ill. So we have 3 therapies that are in for the hospitalized critically ill patients. We don't have anything for the sick at home or doesn't quite need hospitalization patient at this time. So as I was mentioning, a very interesting study hit the mainstream press about a week or 2 ago. And this was based on a supercomputer analyzation of blood samples from thousands of individuals with COVID. And what it showed is what we're now calling the bradykinin hypothesis. So just a few definitions here to help us understand. But bradykinin is a peptide that we have, and it can promote inflammation. So in this disease, the thought is that this virus upregulates bradykinin through a complex pathway we won't get into. But this identifies a lot of, it correlates for physicians especially, because what bradykine's functions are and the symptoms that we're seeing overexpressed in COVID seem to match up. So we're now seeing some, just based on statistical evidence that this might be the cause. And it seems to align a little bit more with the symptoms that are a bit unusual in COVID. You may have heard about COVID toes. You may have heard about kind of the wet lungs and the slime from hyaluronic acid and things like that. All of those can be traced back to bradykinin. So this is a very interesting hypothesis that needs further investigation. And the happy news or good news is that there are already known bradykinin inhibitors developed for other diseases, and I've listed some of those here. But fortunately, I also think vitamin D may play a role. So, there's very little harm in taking a little extra vitamin D, and if you want something else we can do, not to put a run on vitamin D, but there's some evidence that that may actually help block this bradykinin experience. So another thing that I want to touch on now is kind of just a few different things that have hit mainstream press recently and kind of try and give us some of the facts behind that. There's been a lot of concern about seeking healthcare and about what we call the excessive death rate that we've seen throughout the country or the world really this year. And that's probably from two things. What we're seeing is above average death rate. And part of that is, people who've actually had COVID and not being diagnosed with that. So that may be part of it. The other part is probably from people delaying their normal health care, and that's out of lockdowns and out of fear of actually exposures. So I'd like to give us a little bit of science behind why I think people really should be getting their health care now. And that is that UCSF did a very interesting study, and I won't go into the details, but basically they showed that employees were 50% less likely to get COVID at work than they were to get it in the community. And so that would, if you extrapolate, show us that basically coming to the hospital is as safe, if not safer, than going to the grocery store. So if getting food is a necessary thing to do, let's also say that your necessary medical care shouldn't be delayed if the risks are that you could have an exacerbation of another chronic disease or a new disease. So I really think that at this point that healthcare facilities have had time to adapt and put mitigation and cleaning procedures in place to help minimize the risk of transmission. I 100% know that nothing is absolute, but I do feel that when you look at the risk benefits, don't delay necessary health care that could lead to future problems for yourself or your loved ones. So next, I want to talk a little bit about the flu, this idea of a double pandemic, in which would be getting simultaneous COVID and influenza. And that could be either if you talk about it on a population health basis or for a particular individual. Either way you look at it, the results could be disastrous. Healthcare resources are already in very short supply. The clinical outcomes for any given individual from a double infection could be disastrous. They really are two different diseases, and in some instances have competing, shall we say, therapies. And so which to give to aim at which disease could be very complex algorithm to figure out for physicians and may not be very successful, unfortunately, for patients. So what is the message? There's a lot of campaign. We're to get your flu shot now. Make sure it has time to take effect and get it. The downside that some people are worried about is, well, how long does an annual flu shot last? On average, we think it's about 6 months. That science is pretty weak, so I wouldn't hold anyone to that number. But I think in this specific case, the idea is to avoid this double pandemic. So this will buy us 6 months to get COVID under control. And we are very hopeful that we will have some progress on a vaccine and additional therapies after the first of the year, in which case by the time the flu vaccine might be becoming less effective, hopefully there will be more therapies for COVID, and thus we will decrease those chances of a double pandemic. So please reach out to your healthcare provider, get your flu shot now. I can tell you I got mine September 1st. The hospitals rolled out a mobile clinic for all the employees, and we'll be giving it to patients and helping sponsor some community vaccinations as well. So please reach out to your healthcare provider and get your flu shot as soon as possible. So what about the fires? Yes, quite another disaster on our plate. Well, let's quickly mention masks. When fire is concerned, you're really talking about particulates, and a N95 or better may help with the smoke. Unfortunately, a regular cotton mask isn't as likely to be very helpful with smoke. However, due to shortages and the fact that an N95 to work correctly needs to be what we call fit tested, where you literally put it on, adjust the settings and the fit, and then see if you can smell anything, is not really done for the general public. In addition, these remain in extremely short supply. So we're, as a hospital, struggle to get them and to get ones that are adequate for aerosolization procedures and to protect staff and patients. So N95s unfortunately cannot be recommended as a preventative measure for smoke for the general public for many reasons at this time. Therefore, the best recommendations, unfortunately, are to stay inside with the windows closed. So when you put that advice with COVID advice, I guess that means that we're unfortunately going to be quarantining ourselves in our homes a lot more to do that safely, so we don't increase our COVID exposures with individuals outside of our household. In addition, it's very important to have your disaster kit ready and by the door ready to go for an evacuation should that become necessary. Please remember to include a few extra masks in there, as you'll definitely need them wherever you evacuate to. Also important to have plenty of water and food on hand, approximately a 2-week supply for either COVID or a natural disaster. Please remember to include extra medications in that supply so that you can take those with you. If you have a generator, make sure you have access to gas if that is needed, or think about acquiring one if you have the means. And also think about battery backups for devices and to keep some of those in your go bag, shall we say. So there's a lot of challenging conditions between the air quality, fire, smoke, power shutoffs, and COVID, and I think we're all, it's challenged to balance those, but there are resources and help, and I think we will get through this together. So I'm going to change topics a little bit again and touch on schools, kids, and how that relates to COVID. As we know that this has been a big back to school week for many. So this is kind of a compilation of what is known to date regarding COVID. And this was provided by the UCSF infectious disease team, who spent some time looking at all the evidence out there to date. And the conclusions that have been drawn are that for middle and high school age individuals, the transmission is similar to adults. So when you see the statistics in your news about children and their rates of infection, it's not necessarily apples to apples. Remember that children in most cases are considered up to 18. In some cases, if it's drawn from insurance data, they may be including kids up to 26. Just because that's where the cutoff is for insurance. So it's important to understand how a child is defined when you're talking about COVID, because age does seem to play a factor in risk. So there is some evidence showing that in low incidence areas that with masking and physical distancing, transmission can be quite limited, even amongst middle and high school age individuals. The case in elementary seems to actually be more optimistic. There's some evidence that transmission in this age group is lower than amongst adults and older children. And this may be due to a physiological difference. ACE2 receptors are receptors that we have in our lungs and our mucous membrane passages, and that is where the coronavirus enters and attaches. Well, the expression of these particular receptors seems to be lower in younger children of elementary school age. Therefore, they are less likely to acquire COVID-19, but if they do acquire it, the viral load may be similar to adults and they can still become quite ill. So what about teachers? It seems that the risk is much greater for teacher-to-teacher transmission than it is from getting it from a child to a teacher. However, the good news is that masks work and distancing work. And if for anyone who's concerned about a 2-year-old keeping on their mask, which I've actually seen them do quite well, we should be able to expect that older children as well as adults can surely wear a mask and adhere to social distancing protocols. Further, what is the role of testing in educational settings? And that's not really known at this point. We know that having access to it is essential because contact tracing and doing testing as part of that is a very important mitigation measure to, once a case is identified, prevent a larger outbreak. However, how and if surveillance testing can help prevent an outbreak is really unknown. And with the limited testing supplies in our country, it's unlikely to be successful at this time. So let's change gears again, where, as I told you, we're going to touch on a few different topics that have been hot. What about travel? You know, the generalized recommendations are still adhere to essential travel. That being said, most people are doing some sort of travel, either via plane, car, train, whatnot. And some of this is for work and essential purposes, others is purely for vacation. So here's some guidelines, regardless of your reason for travel, that can help you do this in a safer manner. If you are driving, important to drive with household members only. If for some reason you must be in a car with someone who is not in your bubble, then of course, please wear a mask. Hand washing remains very important, and that can be difficult on the road. So make sure you have some of that hand sanitizer that is greater than 60% alcohol, and please use it regularly. As far as food, again, we have not had a lot of success to date in indoor dining and in closed environments. So remember those risk factors and try and prepare your own food, do takeout. It's really about the environment you're eating it in, not about foodborne transmission. So keep that in mind when you're deciding where and how to eat. Again, I know it's very tempting to stay with friends and family, as we all like to do. However, in order to keep everyone safe, the safest thing to do is stay within your bubble, which may mean reserving a private hotel room or other accommodation where you're able to maintain that distance so you're not in prolonged contact. And when you are visiting with those individuals outside your household, just remember those risk factors and try to mitigate them. Bring your mask, keep your visits short, keep them outside or in well-ventilated areas, and again, keep your mask with you. So almost done, but what's next? What does it look like to be living with COVID-19 for the next few months? As we've all seen, it's been with us 6 months and it hasn't really shown any signs of letting up. I believe the US is still having about 40,000 cases per day. So I do think that this is going to continue to be with us until we have some better therapies. As I spoke about, we're getting some therapies and making progress for extremely ill hospitalized patients, but until we have some therapies to help prevent us from patients getting to that stage and or a vaccine, I think we're going to be stuck with this for some months to come. The good news is there are many vaccine trials out there, and although this week we did get news that one of the major ones is on hold to investigate possible incidents of a viral-mediated illness, there are many others out there, and this one may prove to be okay. We don't yet know. On hold does not mean that it doesn't work. It just means that they need to investigate a serious possible side effect before proceeding or administering it to any other individuals. So I do believe that a vaccine is going to be essential to getting us out of this mess, but is unlikely to be rolled out until the first of the year, and will probably take a few months to actually get to enough of the population to allow us to let down our guard. Here locally, the hospital has no plans to go back to shutdown mode, but there are circumstances where we would need to pull back. Those are, of course, if we ended up with a bed shortage. If shelter-in-place guidelines became more restrictive, then of course we would need to follow those. But I can reassure you that from our county partners, from our state partners, everyone recognizes the need to keep services open and not to delay necessary health care. And so there are no plans to make that an early plan of any pulling back. The other circumstances that we continue to monitor closely are our PPE supplies. And so if those were become inadequate to provide safe care for elective procedures or other situations, we would have to make some difficult decisions. And the final shortage that we keep an eye on is our staff, our most valuable commodity. We need healthy caregivers to take care of our community. So we are doing our best to keep morale up and to provide a safe environment so that they can all be in a place to do what they love and take care of our community. So with that, thank you very much. Thank you for taking the time to be here today. And I am happy with Celia's help here to answer any questions that you may have.
Sabrina, thank you so much. I do have a question that came in, and they want to know about they're avid bikers, runners, and they drive around in a convertible. And they're wondering, should they be wearing a mask? One side says yes, the other side says no.
That is a very difficult conversation. As far as riding in a convertible, as long as you're with no one except those in your household, very unlikely you're going to be in the convertible and within 6 feet of someone and it's been well ventilated. So in that situation, I don't know that a mask really can make much sense of. As far as running and biking, this is quite a controversial subject, and I think it's become more of a respect for your neighbor issue, and that if you can wear a mask, that is the respectful neighbor thing to do. We don't have a lot of great sirens one way or another. Obviously, if you are doing those activities in an area where there's no one else around, there is no need for a mask. If there's any chance you're going to be coming into contact with other individuals during this exercise, there have been discussions of slipstreams and other things and breathing heavy, and we really don't have any data for that. And we think that the transmission is unlikely with brief contact, but again, I think the polite thing and the neighborly thing to do at this time period is wear a mask if you have other individuals in sight.
Awesome, thank you so much. I don't have any other questions from the viewing audience. Unless anyone has anything, you can use the chat feature. Otherwise, I think we're going to wrap up today's community talk with Dr. Sabrina Kidd. Again, you can always send us a question. You can send that to us, community@sonomavalleyhospital.org. I want to give a special thank you to Amelia Bustamante for translating the simultaneous Spanish. Of course, to Dr. Kidd, also to Vintage House for their help in promoting and helping us with registration. Our technical team behind the scenes is Vivian Woodall, Faye San Diego, Michael Kovacs, Jade Filippi, and we thank everyone for making this possible. We'll see you next week as we continue the Active Aging series here at Sonoma Valley Hospital. Thank you.
Thank you all.